Good evening, everyone. Good evening, Professor Sawaya. Good evening, all the neurosurgeons from Latin America, and more than 500 people that are online. Professor Ibrahim from Egypt. From now it's 2 o'clock, maybe in the morning. Yeah, from Jordan. From Jordan. And today is a great pleasure to us to have Professor Raymond Sawaya, very well-known neurosurgeon and neuro-oncologist in the whole world. They train a lot of neurosurgeons from the whole world and help a lot the Brazilian neurosurgeons. You have Professor Rota that training him, Professor Maldaun, and many Brazilians that visit MD Anderson during many years. Professor Sawaya, it's a great honor to us to have you with us today. I'm going to give the word to Dr. Rota, Professor Rota. Let's give some remarks, and after Dr. Claudia Yampolsky. Please go ahead, Dr. Rota. Can you hear me?
Okay. Thank you for accepting our invitation. It's an honor for us. It's your time. Start your conference. Thank you very much.
Yeah. Dr. Claudia Yampolsky, please.
Okay.
President of Latin America Federation.
Thank you very much. It's a really great pleasure to be with you once again. And on behalf of the Latin American Federation, we are really proud to sponsor and to support this educational initiative. And as we say, great crises are the opportunity for new advances and of opportunities as well. So we have the possibility this last 3 weeks and today to listen to really an outstanding neurosurgeon and researcher and educator. So really, I appreciate this possibility, and thank you, Raymond Sawaya, to share your knowledge with all the international community. Thanks a lot.
Professor Sawaya, 500 people from 90 countries is waiting for you. Thank you, sir. Please.
Thank you very much. It's a pleasure to be with you, an honor. Thank you, Dr. Borba, President of the Society. Certainly, Dr. Rota, my dear friend for a long time, and Maldon. Dr. Yampolsky, thank you for your comments. And I see many of my dear friends, Al-Mafti, Sbeh, and so many others. Anyhow, I'll just dive into the topic. This is a very large topic. We could spend hours discussing the various aspects. What I like to comment on, which is in the title of the paper, is what are the directions that we're going into? What are the questions about brain metastasis that we have not answered or where we should answer? And so in that process, I have outlined questions about epidemiology, delivery of care, how can we enhance or improve the way we deliver care? Of course, as neurosurgeon, focal therapies are very important for us. This is our contribution to the field. Focal tumors, focal therapies. As you see in my slides, there are a number of options there that are changing and evolving. We'll talk about some of that. And we cannot talk about brain metastasis and not bring up the newer medical therapies, such as targeted therapy and immunotherapy. And I will end with a comment or two about prevention. How can we stop the metastases from getting into the brain in the first place? So let me cover some of these. I probably will not cover everything within the time that I have, but I will try and do this. So according to autopsy studies, in the 50s or 60s, there were 20% of cancer deaths have brain metastasis on autopsy, which in the United States today, that would be 600,000 cancer deaths or 120,000 expected to have brain metastasis. Of course, autopsy studies are not adequate because patients are dead or they may have been too sick. So without a national registry, it is not possible to have the exact number of brain metastases. But what we have, the closest we have, is this paper by Dr. Barnholt Sloan, who was able to look at the tumor registry in the metropolitan Detroit area. This is an NCI, National Cancer Institute, supported program that is covering the entire metropolitan area. This is very important because if you look at patients who are operated on in your hospitals, but then the patient goes to another hospital for radiation, you are going to miss the data. When you have a metropolitan data, that means all brain metastasis patients are captured in this database. And according to Jill, 9.6% of all cancer patients have clinical evidence of brain metastasis. And this translates into about 170,000 cases and new brain metastasis cases per year in the United States. There's no reason to believe that these numbers are different in other countries, but that's the data we have. I'm sure there's more than this number, as I will show you later on in some of my slides. But for now, this is the number that we have. Here's a retrospective I did in my hospital for 20 years, from 93 to 2013, new cases of brain metastases, newly diagnosed cases, not recurrent, not previously treated. You see the graph is a steady rise, steady rise. So there is more and more brain metastases that are being discovered and treated per year, at least in my center. But again, this applies worldwide. Now, a big question that is of interest of mine is which cancer goes to the brain? We don't know the answer to that. There is very little research in that we need to do. This study from NYU, New York University, in melanoma only, they took the primary melanoma cancer and analyzed it genomically and found this particular microRNA, the second one I'm pointing to, that has a hazard ratio of 4.5 to go to the brain. So this is an excellent attempt to go to the original cancer and find out what in this cancer that could predict that this tumor will go to the brain. We should do much more than this than we do right now. Breast cancer, we have some more and stronger data. Here, the study from 2006 showed HER2 overexpression has a 3.5 hazard ratio of risk for this breast cancer go to the brain. Notice that the ER, estrogen receptor positivity, is protective. That means hazard ratio is below 1, is 0.32. So those are markers that are tested in every woman that has breast cancer surgery. So it's easy to use that data in all patients with breast cancer, as my friend Nohad Ibrahim did in this paper, creating a nomogram to predict the brain metastasis in breast cancer women. And the nomogram gives a number to each of these variables. Age, a young patient, 30 or 40 years of age, has a high number. That means a high risk of brain metastasis. A histological grade, HER2 positivity, as I showed you in the previous slide, gets a high number. ER positivity get a 0. So you add all these numbers and you get to the bottom here, probability of brain metastasis, and you will see in this series of several hundred patients, the risk of brain metastasis goes from 5%, which is extremely low, to 50%, which is extremely high. And so now, and they have tested this and did this study in a prospective series. And so now we should be able to tell this patient that had their breast metastasis resected, what's the likelihood over the next 2 years of developing a brain metastasis. And fortunately, and that's the point I'm making, is we have very little of this data today in the literature. And we, as neurosurgeons, we see these patients, we take the brain metastasis out. We should work with the primary surgeons to do those studies in all cancers, and certainly lung, breast, and melanoma are the 3 most common metastases to study. Now, how we deliver care to a brain metastasis patient is also something that is suboptimal. The way it has been and is to this day, patients come from a medical oncologist, breast cancer, lung cancer, or whatever. Then they have a seizure, or they have headache, or they have weakness. They get a scan, and then they either go to the neurosurgeon here on the right, or to the radiation oncologist, or both. And so this patient, as depicted in this diagram, is running from place to place, Monday, Tuesday, Wednesday, and the whole week is consumed in meeting doctors. What we have started in my place, and there are a couple other places, Mass General in Boston is doing that as well. We have created a brain metastasis clinic, and it was important to get the buy-in of the medical oncologist, radiation oncologist, neuro-oncologist, and of course neurosurgeon. And we all meet together. We review all the cases for that particular afternoon. We meet at 1 with a neuroradiologist. We review all the images on all the patients. We agree on a treatment plan, and then we go in the room, patient after patient, and present to them with what the collective wisdom says about the treatment and the option. And satisfaction of patient is very high because of that. Another advantage of this approach is that we enhance our clinical research program. We have tissue specimen in a tissue bank. We have blood collected on these patients. We do the genomic trial. We could create the approach that I just described to you about finding the primary tumor, because as a neurosurgeon, we don't find the primary tumor. We don't see the patient at the time of the primary cancer. But with the medical oncologist, we are likely to be able to get that and then find what best clinical trial or surgery or approach helps the patient. So this really should change the way we treat patients with brain metastasis. Moving on with the focal therapies, surgical consideration is crucial. I have published this with one of my residents, Dr. Al-Shami, on the essential, indispensable role of surgery. And this will always be a necessity. We will always need good technique, good surgical technique to remove a number of these tumors. Now, of course, the field has evolved, as I will share with you, but we should, especially as neurosurgeon, never forget our role and the need to provide that service. So Professor Yazargil has taught us that we can get into any part of the brain and usually do it safely, transsulcal, transcallosal, transsylvian. So I will show you an example of a true Sylvian metastasis in this young 35-year-old male who had melanoma a couple years earlier, presents with headache and hemiparesis. And you could see this gigantic metastatic tumor, severe edema, compression and shift of the midline. You could see the middle cerebral vessels on the surface. So this is a true Sylvian insular metastasis. There is no treatment for this patient today outside of surgery. Immunotherapy that is great for melanoma, this is just too big. Radiosurgery would be prohibitive. Regular whole brain radiation will not touch it. Chemo will not touch it. So outside of surgery, this patient has no chance. And the access is easy. These are usually encapsulated. We get it all out. You do a post-op MRI. You show a clean scan, no evidence of enhancement. You know the tumor is completely gone. And a year later, like we did not operate on this patient. The brain, like an accordion, expands and fills the hole. So that's what surgery can and should offer for patients of this sort. We, of course, published on expected gross total resection, which is about 95% of patients with metastasis. It's not 100%, but 95 is excellent. Morbidity, even in eloquent brain, is exceedingly low, 7% of 200 patients. Overall, 6% neurological morbidity. So we are able, because of the biology of these tumors and modern techniques, to remove them and cause minimal harm to the patient. Now, an aspect that we have focused on recently is the leptomeningeal spread of these cancer cells, especially after surgery. The group of radiation doctors at Mass General had alerted us back in 1987 that these posterior fossa metastases had a high propensity to spread into the CSF, regardless of surgery or no surgery. Alex Olivi, a former resident of mine and a friend of mine, had shown that surgery for posterior fossa metastasis in this small series led to 36% leptomeningeal spread, while supratentorial tumors had only 2%. So why this difference between posterior fossa and supratentorial tumors, we don't know. So we did the study that we needed to do and compare invasive procedure versus non-invasive procedure for posterior fossa metastases. This was published in 2008, and we had 481 patients treated, but most importantly, we had 260 resection versus 119 radiosurgery. And we defined en bloc resection where the capsule is not opened. That is en bloc. If you open the capsule during surgery to get a biopsy and frozen section, that's not en bloc because of the risk of spreading tumor cells. And here we've shown in that paper in Journal of Neurosurgery that piecemeal resections result in 14% incidence of leptomeningeal disease. Radiosurgery had 6%, which is the spontaneous high rate of posterior fossa tumors, but en bloc surgery, 6%, exactly the same, emphasizing that the technique of removing a metastasis is important and that every attempt should be made to stay outside the capsule and remove the entirety of the metastasis, hopefully minimizing this risk. Now, because the supratentorial metastases are much more common, posterior fossa are about 15% of brain metastases, we did the same study in the supratentorial compartment, and here we have shown that indeed there is a low spontaneous rate of LMD, about 1% with radiosurgery, but it's 9% with piecemeal resection of the metastasis. That's a huge number with a p-value that is 0.002. Now, when we looked at en bloc resection, we had 351 patients, so there's no statistical power issue. The p-value compared to SRS is 0.2, so non-significant. The rate is 3%. You could argue there is a trend, but it's certainly very low and is an acceptable trend. So again, the need to do an en bloc resection for these metastases is very important. And then the next obvious question was, if we do an en bloc resection outside of leptomeningeal disease, what's the rate of local recurrence? If we are spilling tumor cells, this will increase the rate of local recurrence. And Akash Patel, one of my residents at the time, did the study published in Journal of Neurosurgery showing that piecemeal resection had cumulatively a much higher rate of LMD than piecemeal resection, and with a p-value of 0.02. So again, everything is pointing towards proper technique, a clean technique of total resection, staying outside the tumor whenever possible. Now, unfortunately, as the tumors get too large, which is above 2.7 centimeter here on multivariate analysis, we start losing the benefit of protecting from leptomeningeal disease or from local recurrence. So it's unfortunate that as the tumor gets bigger, there is likely infiltration of the surrounding parenchyma, and that is a cause for tumor recurrence on follow-up. Now, radiosurgery obviously has become a major force in treating these patients, and I have my perspective on that I will share with you. Back in 1999, I was asked by the Congress of Neurological Surgeons to debate in favor of surgery against Eben Alexander, who was at the Brigham at the time, who used radiosurgery on a Linux system. And there was no data. There was very little data at the time. So I looked at our surgical patient at MD Anderson who were resected, single metastasis resected, followed by whole brain radiation, which was the gold standard as established by Roy Patchell. The only data I could find at the time was a paper by Leffler and Alexander from the Dana-Farber in Boston at the Brigham. They had 500 patients published in the JNCI. And what you could see here, of course, this is not a scientific presentation, but it's a gestalt. It gives you a sense of what happens if you step back and look at the series. Two key observations. One is the first 10 months, the two curves overlap, which means that there is little difference in terms of local control. Some patients may have symptoms from radiation necrosis, but local control is similar for the first 10 months. Now, keep in mind that median survival of brain metastasis patient is about 5 to 6 months across the board. Median survival is 5 to 6 months. So if you do a study looking at differences between the two modalities, you're not going to find it because most patients die before 2 years. Now, if you follow the patients for 2 years, 24 months, you see that radiosurgery fails at a much higher rate than surgery plus whole brain radiation. And so this was my attempt to show that you want to do a definitive treatment here. You want to remove the tumor, follow that with whole brain radiation, which again was a standard of care, instead of leaving this patient that might live 2 years with the problem of a recurrence and surgery and additional therapy. Now, my good friend and colleague, Fred Lang, actually did a randomized study, prospective, randomized study of this question. Many patients were randomized, almost 60, but many more refused randomization and they chose surgery or radiosurgery. I mean, this was a prospective study with very strong, very valid data of patients who qualify for both surgery and radiosurgery. The size of the tumors was between 0.5 cm to 3 cm. So they're adequate for surgery and they're adequate for radiosurgery. And the results of that prospective trial was here. Those who had surgery with whole brain radiation, whether randomized or non-randomized, had at 2 years, at 24 months, had almost 80%, 75% local control, which is what I showed in my previous slide. The radiosurgery patients who live at 24 months, at 2 years, have 55% local control, similar to the 60% that I showed in the previous slide. So this prospective study confirmed what I had predicted, and that is, if a patient lives past 1 year, now again, many patients die within 1 year, but if they live past 1 year, their failure rate is significantly higher and then requiring additional intervention. And so again, our purpose is to have patients live long lives after brain metastasis, and therefore the need to remove these tumors becomes even more acute. Now, having said that, in that 20-year retrospective study that I did at MD Anderson from 93 to 2013, you see what happened in real life. Those that had surgery in the mid-90s were 82% of the patients, and only 18% had radiosurgery. Fast forward 20 years, now 25% have surgery and 75% have radiosurgery. And you could see the green bars, how they are exponentially rising. Now, surgery has been reduced in numbers, but have not gone away. They have plateaued. As you see from the yellow bars, they have plateaued. And the question is, how do we explain that? Since I showed you that surgery in general is more effective. And the way to answer this is here. When you look at the volume of the tumors that we have operated on over this 20-year period, they've gone from 2.5 centimeter medium diameter to 16.8 cubic centimeter, which is roughly 4 to 5 cm diameter tumors. And the radiosurgery has gone from 4.8 cubic centimeter to 1 cubic centimeter, which is almost a little over 1 cm in diameter. So the practice of brain metastasis has shifted dramatically over the last 2 decades, showing that tumors are being found much sooner at a smaller rate, and those that are not being found early are coming to us with a much larger brain metastasis. And here's a living example. A surgeon in Houston, who happens to be a friend of mine, found to have this lung cancer where the arrow is, and I sent him to a thoracic oncologist at my hospital who promptly ordered an MRI scan. No symptoms of the brain. Ordered an MRI scan, and you find this 11 millimeter diameter brain metastasis. This is the reality today in the medical oncology world, especially when it comes to lung cancer and melanoma. Less so for colon cancer or kidney cancer, and in between for breast cancer. So the oncologists are becoming very aggressive in screening these patients and finding these extremely small tumors. And that is making all the difference, as I will show you in the next couple slides. So Eric Chang, who's a radiation oncologist, was at MD Anderson, is now chairman at USC in Los Angeles, published this paper with us showing that local control for tumors that are 1 centimeter in diameter or less is excellent, is about 85 to 90%, very similar to surgery. So, of course, you would say, why operate on them if you're able to control them this well for long? This is 2 years right here, 2 to 3 years. Now, the problem is once the tumor gets above 1 cm in diameter, what happens? Well, we don't know, but we know that all the tumors lumped together give you a local control rate that is dismal, 50% or less at 2 years. So that's totally unacceptable. What the radiation oncologists have not done, and I'm looking into that right now, is where is the stepwise increase, like a dose acceleration with chemotherapy, is where does this drop occur? At what size, what diameter tumor do we have to deal with? And we don't have the answer to that. Personally, I put this curve at about 1.5 centimeter. I believe that once you exceed 1.5 centimeter, you're dropping into a zone that I believe is unacceptable when compared to surgery. Now, that needs to be proven. We have several thousand patients in my institution that I'm analyzing right now to find out if I can show you what the graph will look like if you break down the tumors millimeter by millimeter or 5.5 cm by 0.5 cm and look at this. It's an important question that we must answer. And so here you look at this 20-year review, that patient that we treated with radiosurgery between 2009 and 2013, 99% of them had radiosurgery, but look how many. Almost 1,600 patients were treated in 4 years with tumors less than 1 cm in diameter. So that's an incredible way to detect. We're detecting these tumors. The oncologists are screening their patients much more than they used to before. Of course, we have the MRI that can help. And we're seeing these patients now, and we are not operating on them because their tumor is so small. And that's why you see in the previous graph that 75% of our patients are being treated with radiosurgery at this moment. I will not get into the limitation of whole brain radiation therapy. I think this is well known to all of you. It's now known to all patients as well. So when we operate on the patient and if we send them for whole brain radiation, the patients are refusing whole brain radiation because of the cognitive effect on memory and cognitive function. So what neurosurgeons have done, therefore, they have resected tumors and treated them with radiosurgery, but this was done over several years without only on a retrospective data basis. My colleague Ganesh Rao, who is a neurosurgeon with me here at MD Anderson, Anita Mahajan, a radiation oncologist, did a prospective randomized trial of these patients in a single center and published in Lancet Oncology recently, about a year and a half ago. And what they showed is surgery alone is not good enough. And we knew that from before. That's why we gave whole brain radiation. But if you resect the tumor and then do radiosurgery within 1 month of the surgery, then the local control is at about 75%, 72% at 1 year. So again, these patients are benefiting from surgery, and they're benefiting from radiation without undergoing whole brain radiation and suffering the consequences of that. Now, this is an example of a patient of mine. She had ovarian cancer, and about 2 years later, she has headache, she has a seizure. Actually, she had a very bad seizure. She was intubated and was found to have this very large metastasis. When she recovered from her seizure, I resected it. She received gamma knife radiosurgery to the margin of resection, and here she is, 2 years follow-up. This was a few months ago, no evidence of local recurrence. So we're able to protect the brain without the use of whole brain radiation, benefit from surgery because this tumor is too large for radiosurgery, and enhance the local control and the quality of life at the same time. Now, having said that, the newer concept is now shown here in this slide. The group in North Carolina has proposed the use of radiosurgery before surgery, because if you do surgery and then radiosurgery, you are not protecting this patient from leptomeningeal spread. The time you do the radiosurgery, as I said, is 3 to 4 months after surgery. And so if you have spilled tumor cells into the CSF, then this patient is likely to develop leptomeningeal disease. You may improve the local control with the radiosurgery, but not the LMD spread. So they are proposing to do radiosurgery first, and then a couple days later, because the margin has been so-called sterilized, you can go in, resect the tumor, no need to give radiation anymore, and hopefully prevent leptomeningeal spread. There is no prospective data on this. This data that they have is retrospective. We have started a prospective randomized trial in my place to answer this question. I'm sure others are doing that as well, and hopefully we will have data to share with you at the next meeting. To move on, I just want to quickly mention that even though a tumor is appropriate for radiosurgery, as this one I'm showing you here on the left, it's a 12 millimeter metastasis near the speech center. Okay, so we treated this patient with radiosurgery, but look what happened. About 9 months, 8 months later, horrible looking mass, terrible swelling, speech impairment. This patient was very, very symptomatic. Of course, this patient was on steroids, and despite that, did not get better. And so we operated on this patient. And so I was curious to see what happened to these patients. And so we published this paper in 2005 with one of my fellow, and you notice that Dr. Maldon was with us at the time and participated in the study. What it shows is that patients become steroid dependent, and some for months before they are operated on. Many of these patients were not in my center at the time of the radiosurgery and recurrence, and that's why they may have been so long on steroids. But once they come to us, and we had 61 patients that we operated on, we're able to reduce the steroids. 80% of the patient are off steroids in 3 weeks. Unfortunately, some have deficits that are long-lasting because of the duration of the deficit before surgery. And interestingly, we're able to salvage these patients, especially RPA1 and many RPA2 patients. These are better prognostically, clinically prognostically patients. Some are living many years. RPA3 are dying rapidly, and so treating those patients really makes no difference. So that was an important study that we wanted to show. And all patients had tumors in their tissue. Only 4 of the 61 has true radiation necrosis. All of the others had tumor cells along. And that's why, the radiation necrosis may have gotten better with steroids, but tumor is not going to get better with steroids. So in closing, about the role of surgery, we should always keep in mind that we are able to taper steroids rapidly. We enhance the recovery from a neurological standpoint. The follow-up is much simplified, as shown in this patient who failed radiosurgery. I resected the tumor, and you could see the follow-up looks excellent. So this patient is doing well. And so decision-making is much facilitated when you do that. When you have tumor left there, treated with radiosurgery, enhancement, edema, swelling, or whatever, you are not sure what you're dealing with, tumor or what. So again, that's an advantage of surgery. Very quickly, I just want to make 2 points about molecularly targeted therapy. This is chairman of pathology at MD Anderson, a friend of mine, Dr. Wistuba, who's from Spain originally, has shown, he's a lung cancer pathologist. He has shown that if you compare the primary lung cancer with the brain metastasis lung cancer, there are significant differences in the HER2 family or EGFR family of molecules. And that's the conclusion here, is our findings suggest that non-small cell lung cancer brain metastases have significant differences in HER family receptor-related abnormalities from primary lung tumors. And this has implication on the medical management beyond surgery and radiation for these patients. And so we as neurosurgeons, as we take this tumor out, is very important to preserve the tissue and to allow this kind of studies to show whether there is concordance or discordance between the primary tumor and the metastatic tumor. Now, of the 2 approaches that are widely used now, the BRAF inhibitor is now becoming very widely used, especially for melanoma. And it is an important approach, but I caution that you will see no complete response. Here's CR, complete response, 0, 0. This cohort A, cohort B is a combination of BRAF inhibitor. You do get good partial response, stable disease, of course progression, but complete response is not happening. So that maintains the role of surgery for many of these patients. Now, here's a very interesting example. It's not surgical, but this patient with melanoma has about 30 metastatic tumors. This is the most impressive one in the brainstem. Look at the date, June 6. 2 months later, 2 cycles of BRAF inhibitor, this tumor shrunk to about less than 5%. Again, as I said earlier, not complete response, but a tremendous response. And frankly, nothing will do this to these tumors outside of this inhibitor. So there is definitely a role for these targeted therapies in select patients. What's more important, though, is the immunotherapy. This has been shown in melanoma, as my friend Hussein Taubi, who's a medical oncologist at MD Anderson, has shown in this New England Journal of Medicine paper, along with many of his colleagues. The response of melanoma brain metastasis to combination immunotherapy, Nivo and Ipi, has shown durable response at 2 years. You could see here about 70%, 80 to 70% response control and progression-free survival. And what's interesting is that extracranial and intracranial disease are equally affected, which shows you that this is a very powerful and durable way of treating these patients. The good news is that many lung cancer patients are responding, maybe not as well, but 50% of lung cancer patients are responding to this combination immunotherapy, and the majority of kidney cancer are responding to that. To my knowledge, breast cancer has not yet shown response to this approach. But for melanoma, which is a problem that we see quite frequently, this is truly dramatic and superb. So I'm going to close in the last 3-4 minutes that I have left on prevention. Remember what I said at the beginning. The median survival of a brain metastasis patient is around 5 months. So it is a very bad thing when a cancer goes to the brain. There are a subset of patients, as I showed you in many of our studies, that live many years, but on average, 5 months median survival. So obviously, if we can find a way to prevent this metastasis from the primary cancer to get to the brain, we would do great service to our patients. And you're all familiar with the metastatic cascade of events, from the transformation to transvasation to implantation into the lungs and eventually into the brain, and to form a brain metastasis. This is a very arduous process. Millions of tumor cells try to do that, and the overwhelming majority of these tumor cells are killed by our system, immune system or environment, and they cannot succeed in implanting. Few of them do, and the question is, if this is so arduous to get to the metastatic site, can we interfere while they're trying to get into the blood and before they get to the brain? And there are a number of approaches that various scientists have tried. This is one of them. One of my faculty, Sue Huang, who's a basic scientist, is a world expert on STAT3. STAT3 is a very important regulator called signal transducer and activator of transcription 3. And STAT3 plays a very important role in providing the malignant phenotype to tumors, including glioblastoma. So we're very interested in blocking STAT3 in glioblastoma. For metastasis, it's very interesting because STAT3 will suppress immunity, will produce angiogenesis, increase migration, which promote metastasis, and of course survival and proliferation. All these are malignant phenotypes. Sue Huang had an animal model and with Waldemar Priebe, a biochemist who developed STAT3 molecule. It's an oral molecule with excellent blood-brain barrier penetration. Edmey Heimberger, who's shown here on the right, obtained an IND from our Federal Drug Administration and is now testing this drug in a phase 1 trial to make sure the toxicity is low. The toxicity in animals is extremely low, so we expect it to be tolerated by humans. And when Sue Huang tested it in her animal model of brain metastasis in this breast cancer trial, where the control animals had this number of brain metastasis, giving the drug intraperitoneally 3 days before injecting the tumor cells in the carotid, which is what she does in her model, we had 68% reduction in large metastasis and a similar reduction in micrometastasis. So this could prove to be an extremely beneficial approach to patients who have cancer diagnosed early before any brain metastases occur, to put them on an oral medicine that hopefully will reduce 60% risk of brain metastasis. This would be a great service that we would make and give our patient with brain metastasis. There are other approaches that I know of, other scientists are attempting to try, but this is as far as advanced as I've seen in terms of hopefully once Amy proves that this drug is safe to humans, then we can team up with our breast oncologists and apply this to women with newly diagnosed breast cancer. So in closing, brain metastases are the most common intracranial tumors. Neurosurgeons' involvement is critical. Selection of optimal interventions require neurosurgical wisdom, minimize leptomeningeal spread through proper techniques, and harvest tissue for molecular mapping. All these are things neurosurgeon can and should do to help in managing these patients. The need to foster strong multidisciplinary ties is essential. This helps to care with patients, learn of what our medical oncologists have to offer, and merge those newer techniques with what we can offer using focal therapies. And ultimately, though, research should be aimed at protecting the brain through preventative measures. Thank you very much for inviting me, being with you. Many of my friends are there, and I'd love to be with you, but right now we are confined at home. Happy to answer any questions.